Okay, good morning. I'm Jane Finley. I'm a pediatrician here at BC Children's Hospital, and I've done a fellowship in infectious disease, and I've worked on the Canadian Pediatric Society Infectious Disease and Immunization Committee. So sometimes people call me the shot doctor, because just we have to do disclosures. So funding for this program is being graciously given through an unrestricted grant from Merck, so thank you very much. And I personally have received lecture fees from Novartis and Pfizer. So this vaccine program has just been mired in controversy since its inception. It was brought into the school system here in September 2008, and there's been a heck of a lot of resistance generally and from faith-based groups. And then in 2012, we had the recommendation for vaccination of males as well. But we know that the uptake is disappointingly low. This headline was in recent Vancouver Sun showing that only 2/3 of girls in grade 6 are getting their vaccines, especially in the Fraser Valley. Some religious schools, it's even lower. And overall, by the age of 18 across Canada, there is some catch-up, but it's only 70%. And this vaccine equals MMR in its depths of controversy of whether parents choose to get this vaccine for their children. And you really have to wonder why. Because I tell people, my gosh, this is a vaccine for cancer. And if this was a vaccine for breast cancer, the girls would be lined up down the hallway, right? But I think it's the ick factor, to tell you the truth. Many people feel that, well, their child isn't going to get the disease, and I usually tell people, even in a traditional culture, your daughter will likely be a virgin, but maybe her husband won't, right? You've got a 50-50 chance of getting it from him. They're worried that giving the vaccine will be a license to go out there and have sex, but I think that's kind of like not letting teens wear seatbelts. You know, if we wear seatbelts, then you won't drive too fast. You know, I think that people don't understand why we're giving it in grade 6, and I think that we could have more education on that point, that, you know, it's stronger, it works better, you only need 2 doses. And also there's a conspiracy theory of Big Pharma, and this was even in the Canadian Medical Association. Remember that we were all in league with Merck, and our girls were being guinea pigs. So great news that BC has extended the funded program to at-risk males, but I personally think it's not enough, and certainly the BC Pediatric Society strongly recommends the universal program for girls and boys. It's interesting that this free program extends to gay men, gay boys, but also those in foster care, street involved, and those boys who are questioning their sexual identity. So I think there's a lot of leeway here. I've told my son he's going to be gay for the day, and you know, who knows? And you can order this vaccine into your office, so they don't have to go line up at the public health clinic. I'm a bit concerned that you're supposed to identify them, and maybe some boys might not want to be on the list. I don't know, but there it is. So you can order it into your office. So.
That includes HIV patients?
Yes, oh, definitely. Well, they are funded, right? Yeah.
But it's also age restricted.
Yeah.
Well, we're going to down. It's up to age 26.
Yeah, up to age 26, but yeah. But this will be part of the program. So we have an amazing list of speakers today. We're really going to cover HPV from top to bottom and the impact of this vaccine. And our first speaker is Diane Miller. So Diane Miller is the Division Head of Gynecological Oncology, Provincial Gynecological Tumor Group Chair at BC Cancer. Dr. Miller's divided her training between UBC and Toronto, and actually worked as a family doctor. I found this really interesting, in Yellowknife, Northwest Territories. Dr. Miller is actively involved in both clinical trials and collaborations with translational and basic scientists. And her particular interest is looking for potential screens for early diagnosis and in targeted therapies. So if we could welcome Dr. Miller, please.
Thank you. I think everybody should do a couple of years of family practice before becoming a specialist. It certainly helped me. Great. It's nice to have somebody do this. Okay, I'm at the reading glasses stage, so I'm not really sure if I will be able to see my slides. So if I have to put on the reading glasses, I apologize. So I'm going to start at the bottom, HPV from top to bottom, and I'm going to start at the gender bottom. I'm going to start with adult women and HPV infection in adult women. Okay, why am I not advancing the slide? Not with the mouse?
You can just use.
Oh, just with these ones. Okay, great. So I've participated as an investigator in clinical trials for GSK and Merck. I've also received speaker fees from both Merck and GSK. And I didn't put here that I'm on an advisory board for AstraZeneca, which is not relevant to HPV. So my objectives are to describe the burden of HPV-related disease in adult women and to cite some of the evidence for the benefits of HPV vaccination in adult women, and also to discuss some data supporting the 9-valent vaccine and provide some recommendations related to HPV vaccination. I had to go through my talk last night, and as I looked through the agenda for the meeting today, I knocked out all the boy slides, I knocked out all the screening slides, I knocked out all of the head and neck slides and everything. So I'm going to restrict myself predominantly to the gynecological implications. I think the first thing we need to know, and we know this from a cancer standpoint, is HPV is everywhere. And probably everybody recognizes Michael Douglas from his disclosures a couple of years ago. Looking around the room, probably some people weren't around when Farrah Fawcett was around, but she also was very public about anal cancer, which is another HPV-related disease. Oh, sorry, that's his throat. Usually I get to give my talk just before lunch, so I get to show the gross pictures. And these pictures, this is a vulvar cancer, a very sad story of a vulvar cancer, a woman in her 40s who actually was a nurse, and she thought she had condyloma, and she was so embarrassed about having condyloma that she actually didn't seek medical care until she was admitted to her local hospital for depression, and the family doctor that went in to examine her noticed a very peculiar odor, and she disclosed that she had this lesion on her vulva. Suffice it to say, she ultimately died of her vulvar cancer. Here's a cervical cancer. We do see about 140 cases of invasive cervical cancer in British Columbia every year, and a third of them will die of their cancer because it's diagnosed at an advanced stage. And this is more usual what we see for vulvar cancer. I'm not going to go through head and neck, and certainly as a gynecologist, not penile cancers. One of the things I would like to comment about anal cancer, though, is me as a GYN oncologist, I always thought anal cancer was more common in men than it was in women, because there's so much publicity out there about men who have sex with men and the risk of anal cancer. But in actual fact, more than half of the anal cancers are in women. So it's and you'll hear about that, I'm sure, in one of the later talks. So what about HPV infection? Well, as I said, it's everywhere. And it comes in two varieties. It comes in the high-risk HPV, and it comes in the low-risk HPV. And HPV is responsible for the development of cancer precursors at many sites, and we're going to hear a lot about this today. But low-risk HPV, as you're probably going to hear about, also is not a problem. I'm forever telling my patients in the colposcopy clinic that nobody ever died of warts. They just think they're going to die of warts, right? And it's interesting from a gynecological perspective how much more upset women get about having genital condyloma than they do about having an abnormal pap smear and CIN, where the CIN is the one that's going to kill you, not the warts. But culturally, people get very disturbed about having condyloma, so we shouldn't forget that. So what's the burden of HPV in Canada? Well, in the country, we get about 450 deaths from cervical cancer, and as I said, in our province, we get somewhere between 40 and 50, our usual 10%. There's a lot of cervical cancers that get treated, and it's pretty consistent that 1 in 3 will die when they get invasive cancer. Genital warts, lots of cases of genital warts. And CIN, most GYN oncologists and many gynecologists make a good living treating CIN. What about British Columbia? Well, every year there's about 600,000 pap smears done, and I'm not going to go through the screening recommendations because Gina's going to talk about that later. About 1/10 of them are abnormal, so 60,000 women will have abnormal pap smears. Most of the time that will just result in them being asked back to have another pap smear in 6 months because most of them are nothing. But about 7,000 of them will be referred for colposcopy each year in British Columbia. And of those women referred for colposcopy, almost 1,500 of them will have a treatment done to their cervix. Most of the time, the treatment involves removing the epithelium of the cervix with a treatment called LEAP, or it could be laser. We've actually stopped using cryotherapy in British Columbia because it interferes with the ability to do pap smears in the future. And we did see that even though it's an effective treatment, it's hard if they recur to diagnose. So does it cost us anything? Well, there was an analysis done at BCCA several years ago, now 10 years ago. And at that time, it was estimated that HPV was costing $37.4 million. And I doubt that it's actually decreased in cost since that time. But the bulk of the money we spend on HPV is on the cervical cancer screening program. And that's just shown in this pie diagram, is that looking at cervical cancer, obviously there's only 140 cervical cancers, but the money that we spend to prevent those cancers is tremendous. And then the second biggest bar is the condyloma, which is the non-malignant disease. So this is a slide from Quebec, and this slide just shows you that proportionally the cancers that are caused by 16, 18. And as you know, the 3 available viruses all cover 16 and 18, and that accounts for the vast majority. Just talking about the 9-valent vaccine for each of the sites, you can see that you get a bump up in terms of the ability to prevent more lesions. And being a gynecologist, focused mostly on the cervix and the vulva and the vagina, of course, but the cervix, which is the major area of focus, and you get quite a significant bump from about 70% protection to about 90% protection. So just a little bit about genital warts. The vast majority of genital warts are caused by type 6 and 11. And in fact, if you look at the Australian data, somebody came out and said maybe they're all caused by 6 and 11, because they basically, you'll see from a couple slides that I'm going to show you next, that they basically had a disappearance of genital warts secondary to their wide coverage of vaccination with the quadrivalent vaccine. Sorry, this seems to have done something. I just wanted to, from a cancer standpoint, because I know you're family docs and pediatricians, but from a cancer standpoint, I think we should not underestimate internationally the importance of HPV in the genesis of cancer. And it's estimated that almost a quarter of all cancers worldwide are HPV related. And that's because even though we only get 140 cervical cancers, the rest of the world is not so lucky because they don't have screening in that. And almost 250,000 women will die of cervical cancer every year. So we're sitting in a room here in a developed country talking about vaccination and that, but I think we all have a responsibility to lobby our various governments and that, really make sure that this incredible preventative strategy actually reaches the people who are at most risk. So I just also want to, one of the things that I get asked all the time is, should, obviously I'm in a stable relationship, blah, 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 blah. I always say to women, I don't know what you're doing and I don't know what your husband's doing, and I don't have the tools to figure that out, right? But what I do know is that people do still acquire HPV, new strains, as they go on later in life. And there may be many reasons for that. Marriages break up, new partnerships, etc. So we're not immune to picking up HPV just because we've been around for a long time. And we do see this bimodal distribution. The available vaccines right now are the bivalent vaccine that covers 16, 18, the quadrivalent, which is the one still being used in the schools. I'm not the expert. The 9-valent vaccine is new to the game, and that's the one that I think we're probably focusing on today. And certainly, I think from an oncological standpoint, the one that I personally am most excited about. This bar graph here just shows you that type 16 is by far and away the most important contributor to cervical cancer, followed relatively closely by 18. And then each of the other subtypes incrementally contributes less, but when you add the next five most relevant ones, you get up to a bump of about 90% coverage, which is pretty good. And from an oncological standpoint, and I'm not the screening expert, but I think you should ask Gina, is there a point of vaccine coverage where screening will become irrelevant? Because I think if we got 100% coverage of our population and we prevent 90% of the HPV-related diseases, then the cost of pap smear screening by far outweighs any of the individual or any of the cases that we're going to get. And it may be in the future that we will be looking at different algorithms for screening. You know, recent immigrants might have a different algorithm than somebody that's been through the school program, that's been vaccinated. I think one of the tragedies here is it's very difficult for the vaccination programs to actually talk to the screening program. Manitoba has done it well, but I think British Columbia is way behind in terms of allowing those registries to talk. So I think I already said this. I don't know why the 9-valent bar is bent, but maybe that's a good thing. Just to go over again, for cervical cancer, 70% is covered by the quadrivalent and the bivalent vaccine via their 1618. If you look at CIN 2 and 3, I did show you that we're doing over 7,000 colposcopies a year in the province. We could cut that in half by having a good vaccination cohort. So that would make for a lot less colposcopies that need to be done in the future, and then obviously a lot less treatments. Just a little bit about cancer of the vagina and cancer. Cancer of the vagina, incidentally, is very rare, and most of the cancers of the vagina are actually cervical cancers where the woman's had a hysterectomy, but there's still a dysplasia at the top of the vagina. She doesn't have a cervix, so it's a vaginal cancer. And that can progress to cancer, or cancers of the vulva where they're encroaching on the introitus and lower vagina. So the vagina, the mid-vagina is actually a very, very rare site to get cancer. So the vagina per se, most of them are probably just spillovers from the organs on the top and bottom. Vulvar cancer, second to cervical cancer, is the second most common HPV-related cancer that we see in gynecology, but even it is not all that common. But what I would like to point, and vulvar cancer, not all of them are related to HPV. About a third of them are related to chronic irritation associated with lichen sclerosis, P53 mutations, etc. And they're quite different. They look different to the pathologist. They don't have the VIN precursor lesion that we see. And so there are vulvar cancers that are not HPV related, and I believe that probably also holds for some of the other sites. But certainly cervix, it's, I think, 99.97% of cervix cancers are related to HPV. The majority of vulvar cancers are related to HPV, and the vaginal cancers, from what I've talked about before, being spillover from cervix and vagina, are also HPV related. If we look at you know, the nonavalent vaccine, and we were very lucky in Vancouver. I think between BC Women's and VGH, we had over 400 16, it should say 16 to 20, or well, I know 6 to 26, but the trial was 16 to 26 years old. And we had over 400 women enrolled in that trial. And really very, very good compliance with it. But what we do know is that at the end of the day, the efficacy of the nonavalent for the non-16, 18, 6, 11 subtypes was pretty much as good as we saw with the original quadrivalent vaccine. So I think we have very high hopes that it will perform in the long run as well as it will in the, or as it did in the study. And the same actually holds for the vulvar vaginal and persistent infection, very similar to the results that were there for the quadrivalent vaccine when it came out, and the bivalent vaccine. How we know it works? Well, I think, you know, all of us who are in the oncological world felt that the first thing that was going to happen is we'd see a fall off in genital warts, because we see genital warts in our clinic generally fairly closely after sexual debut, and most of the genital warts, and I argue with the Merck people who come to my office all the time and tell me genital warts are important in the 30s and 40s. The reality is women who get genital warts in their 30s and 40s usually get one wart or something. The late teens and early 20s can get florid condyloma, and that's where we see the people that are incredibly distressed by venereal warts. So our prediction is that when we started to see young women or girls being vaccinated, that the first thing we would see would be a fall off in genital warts. Fortunately, Australia started their vaccine program before us, so they actually were able to confirm that. And they had a virtual disappearance of condyloma in the vaccinated under 21 women. And I think also it's interesting, they had a fall off in the unvaccinated, which is sort of the first clue that there might be a little bit of herd stuff going on. And this is, again, Australian data, and this is just looking at the number of people who required treatment for genital warts. And as I had said before, the late teens to early 20s was the group that we really see. And prior to vaccination, you can see that that's the group that required all of the treatments for condyloma, and it fell off precipitously after vaccination. So there's been a virtual disappearance of all genital warts. And as I said, some of the folks in Australia say, well, are they all 6 and 11 then? Because certainly that's not what we believe, that we believe there's other low-risk types that do contribute, probably about 10% of them. But there's definitely a herd effect for both heterosexual men and possibly unvaccinated women. There was no protection in Australia for men who have sex with men. And I think that was the first sign that maybe this is going to work for CIN, which is really what we want it to work for. And I'm not going to go through this because Gina's coming and it's her data. So Gina Ogilvy actually looked at an ecological analysis of what's happening to CIN2+ in British Columbia. And she'll go through this in more detail. But basically, they took women who were 16 years old at different times, and there's been a fall off in the rate of CIN2+, which are the high-risk lesions on the cervix. Now, I would just like to put a little plug in here. This is a really interesting study, but we sure don't recommend doing pap smears on 16-year-olds. We recommend that you don't start till age 21, and it's the bane of our existence when we see a 17-year-old referred to the clinic with an abnormal pap smear, because almost inevitably these will disappear. I don't believe in my career, which is now encroaching on 25 years, that we've had a 20-year-old that's had an invasive cancer of the cervix. So what we don't want to be doing is medicalizing and traumatizing young girls by doing pap smears, even if they're sexually active, to prevent something that's not going to happen. So I'm very much supportive of we're actually even thinking of starting the program at 24, and I'm not, as I said, I'm not going to get into that. But right now, the recommendation is for age 21, and certainly encourage people to do that. Gina would never have had this data if everybody didn't disobey that. But maybe we'll have to do an Ontario thing. Ontario has implemented, if people are being screened more than the recommendation, they just throw the smear out. So they're not willing to do, they have a 2-year program, and they're not willing to screen people every year who do not need to be screened every year. It's a cost, a huge cost. I want to just have you have a peek at this slide, because this is where it's important to me. I do a lot of work in the colposcopy clinic. So we treat women for cervical intraepithelial neoplasia, vulvar intraepithelial neoplasia, and some in the vagina. And what I thought was really interesting is because the vaccine is actually a prophylactic vaccine. It's a preventative vaccine. It is not a therapeutic vaccine. We know that it doesn't treat pre-existing disease, but we do know that a not insignificant number of women, somewhere around the 10 to 15% of women, after we treat their VIN or their CIN, will have a persistence of their HPV infection. And those women remain at increased risk for the rest of their life of getting HPV-related disease and invasive cervical cancer. And I'm sorry I don't have a slide, but we actually did a study looking at women who had been treated for CIN3 in the province, and I believe they have a 4-fold increase in the risk of getting invasive cancer in the future, even though they've been successfully treated for that. Though that's because of persistence of the HPV infection. So what we do know is that there is evidence from the Future 1, Future 2 studies on the quadrivalent vaccine looking at the persistence in those women who were on the trial who usually had been, because they weren't screened for being HPV negative at the beginning, who were treated, and there's a decrease in the persistence. We're lobbying to try and get this group of women covered for vaccine under the age of 45, because I think this is another area where we can make an impact. And it's not a huge number of cases, it's not a huge public health cost, but if we can decrease the persistence of HPV, we provide a real benefit in preventing invasive cancer. So this is actually quite an important thing. So what do we know about the vaccine? Well, it's best given before sexual debut. The school program, probably, I'm not going to go through that because there's a lot more experts than me. So far, no booster is necessary, and there's over 10 years of follow-up. Older women do require 3 doses, and I think it's really important to emphasize that if you are vaccinating older women. It does appear to work, and it appears to decrease the risk of viral persistence, which you don't hear a lot about. Yes?
Is there an age cutoff at all anymore?
Well, we follow the NACI guidelines. So if somebody comes into my clinic and they're 70, I don't recommend an HPV vaccine. But
Somebody's 38.
Yeah, I do. I mean, the NACI guidelines are under age 46, right? So we would, up to age 46, we would recommend that they consider HPV vaccine. And we do synoptic reporting for colposcopy, so we just have little tick boxes, and we now have a tick box that says recommend HPV vaccine, and we try and remember to talk to women who have been treated and recommend that. The other thing, we will write a lot of prescriptions in the colposcopy clinic. And one of the things that I think you all know is the pharmacy will just give it on the spot if you have the vaccine.
Can I just quickly interrupt? If you're going to ask a question, would you mind turning on your microphone, because we have people on WebEx and they can't hear your question otherwise.
Okay,
Thank you very much. Sorry.
Oh, yeah, okay.
So what age is older women on the 3 vaccine dose?
Unfortunately, it's way younger than you think. It's like, what was the study? Was up to age, it was the 16 and over is older
16,
women. Yeah.
oh, okay.
And okay, so yeah, I know it's kind of sad. I mean, I don't know if we are all ultra old women, but I don't think there's a description for that. So I'm not going to go through the boys thing, but I just put this slide up because I do want people always to keep in mind that the big burden of HPV does fall on women. I'm a gynecologist, right? Cervical cancer screening, I'm just going to say a little bit about it. Our program in BC began in the 1950s. It was the world's first ever population-based screening program. It's been widely published on and emulated. It's our provincial program. It's all done, the cytology is all centrally. It's organized colposcopy. And in spite of that, our coverage, women who have had a pap smear in the last 5 years, 75%. So if you think screening is the answer and people say, well, you don't need the vaccination because you have a good screening program, in spite of every effort that we've made through BCCA in my 25 years that have been there, we're unable to get almost a quarter of women to regularly participate in the screening program. That quarter of the women accounts for about 70% of the cancers that we see. So we're not doing as well as we would like, and we're bang on the Canadian average. Okay, why does screening not work very well? Well, lots of women aren't being screened. I've just pointed that out. There's also, some performance issues. And one of the things about being a family doctor, I've been in the shoes of the family doctors, and I know there's a couple in the room. And I remember when I started in Yellowknife, I remembered a woman who was like a gravida 10, right? And I stuck the speculum in, and the vagina was just billowing into the thing. And there's a limited amount of time you can spend looking for that cervix to do the pap smear, right? Like, I mean, there's a point where it's not really reasonable 10 minutes, 15, 20. I don't know what the point is for you. Probably for me, it was about 5 minutes. So what do you do then? Well, you take the stick and you squirrel it around somewhere up top and hope you get somewhere near the cervix. So, there's those kind of difficulties. Sometimes the cervix is not always accessible with fibroids, it's posterior, etc. And then also, the pap smear, we kind of think of it like a blood test where you're measuring a hemoglobin. It's not. There's a human being looking at a slide, and it is possible for things to be missed. And, sometimes there's scant cells. Sometimes there's a whole bunch of inflammation or blood on the slide, and they're going to have to find those 2 pre-malignant cells that are on there. And there's been lawsuits about that where people scrupulously look at a pap smear after someone's diagnosed. Oh, yeah, we found 4 pre-malignant cells on there that the cytotech missed. So it's not perfect. The reason it works well is because people are screened regularly. Having a single pap smear is not that effective. Inadequate follow-up. Sometimes we actually diagnose a pre-malignant lesion on the cytology and there's a recommendation for colposcopy and they never get there for whatever reason. They choose not to come, which is kind of interesting because why did they choose to have the pap smear and then choose not to follow through with it? I don't know. And then treatment failures. And, there's also a little bar for rapid evolution of cancer, but that seems to be a very rare event. One thing we do know, though, and I suspect all of you in the room were taught that you start with CIN1, then you get CIN2, then you get CIN3, and then you get cancer. That's all rubbish, okay? Because what happens is you get infected with a low-risk virus or you get infected with a high-risk virus. And if you get infected with a low-risk one, you get CIN1 or ascus-type pap smears. If you get infected with a high-risk virus, you get the HSIL or CIN2, CIN3, and or invasive cancer. So it's not progressive like we were all taught in medical school. So pap smears have been quite effective, but one of the things we do know is that more recently it's really plateaued. I think we've accomplished what we can with pap smears. We can't get, we can't make a law that people have to have a pap smear, etc. So we've accomplished what we can. So since the BC program started, there's been a 70% decrease in the incidence and mortality of cervical cancer, but we're probably never going to get below that. Now, treating CIN is also not without problems, okay? So we think, well, it's no big deal. You go there, they do a leap, they take the epithelium off the cervix. But there's fairly good evidence that we can increase the work of pediatricians by increasing preterm delivery. Usually it's not severe preterm delivery. It's usually sort of the 36 to 40. So it's, what do you call it if it's 32? Bad prematurity. I don't know. I don't do obstetrics anymore. But it's usually not the extreme prematurity. But along with that, there's a low birth weight. Incompetent cervix is usually the cause. Premature rupture of the membranes is higher. And then on the other side, there's cervical stenosis and a higher risk of cesarean section in people that have been treated. So it not only causes incompetence, but it causes supercompetence of the cervix. And then a little bit more controversial is infertility and women who have had multiple treatments to their cervix. If you remove all of the glandular epithelium from the cervix, they have no cervical mucus and would require assisted reproduction. So I'm going to quit here, and my summary is I'm going to say the HPV vaccine, in my opinion, is very effective, best before sexual debut. I'm not going to talk about boys. It may, and there's good evidence that it decreases the risk of persistence in women undergoing treatment. And I think, from an oncological standpoint, it has the potential to eradicate almost a quarter of all cancers worldwide. And that's huge. So thank you. I think they all have asked their questions.
Yeah, well, we've got lots of time, so we have lots of time for questions.
0116.
Well, I have a question. So if a woman, say you have one of these high-risk women, she's had the 4-valent vaccine, are you revaccinating with a 9-valent or topping up, or what are you doing with that?
So in the clinical trial, they were all, because I think that's an important question, and I think it's important for two standpoints. One is, should we do it? And the second is, are they going to have problems because they're already immune? And so we were involved in the quadrivalent versus nonavalent trial. And I would say about 2/3 in our center, our site, 2/3 of the women who were on the quadrivalent arm elected when the study was unblinded to come back and have the nonavalent vaccine. I'll tell you, they had no problems. It was slightly sore when they looked at it, but they didn't get big ulcerated problems or anything. So the first part of your question is, can you do it? Yes, you can do it quite easily, okay? And we haven't had anybody have any problems. And then the next one is, should you do it? And I'm a little bit more fuzzy on that. I think if you wanted the absolute best protection possible, if you were a woman and you wanted the absolute best protection possible, sure you should. But I think I also showed you that the bulk of the lesions that we see are still 16 and 18. A lot of the young women that we see in colposcopy don't have a lot of money, don't have extended coverage, so it's not really an option. And then the other thing that I didn't go into is the 16 and 18 from an oncological standpoint are definitely the most virulent. Like they're the ones that can escape through screening, and that the progression to invasive cancer is much quicker. So the next 5, possibly there would be a better chance to pick up on screening in that. So I haven't been pushing women who have been vaccinated with quadrivalent to come back and have the nonavalent. That being said, if somebody said, I want the absolute best coverage possible, I've had the quadrivalent, I hear there's a new one, can I get this, should I get it? Absolutely, they can get it. How's that for waffling?
That's great.
Question, since you said that it was 16 and older was where they needed the 3, if you had, let's say, a student who had their first shot when they were 12 and they missed the others, and then they're all of a sudden in, let's say, last year high school, so they're 17 years old, would you have to restart the whole series or not?
So I'm not the vaccinologist, but if they wanted the quadrivalent, you have to, or the nonavalent, they have to restart the whole series. And you can't have 2 quadrivalents and 1 nonavalent. It doesn't work that way. Well, you'd be probably fine for the quadrivalent part, but not for the 9.
No, it's Vincent.
Joined by WebEx, so maybe we can ask them if they have any question. Right, people joined by WebEx, do you have any question? You can ask right now. Silent mean no? Okay, thank you. And we have one question here.
So to continue her question, this girl who has had 1 shot,
I mean, sorry, would it be easier if he paid for this on his
Do you know,
credit
can
card?
I
Like, does that
actually
make any
defer?
sort of
You've got the
difference?
vaccine people, the vaccinology people coming. My feeling is, I think there's probably a time limit that you have to do it. But I think the other thing is that because she had her first one at 12, she might be a different animal than what I see in the office, right? Because I see people that are getting vaccinated at 26, so it's really easy to answer that question. They need to start over if they're 5 years later, right? But I don't know the answer for the pediatric
And I
population.
doubt it's been subjected to a clinical trial. Do
Yeah.
you know, Marilyn? If you have that big gap between the...
But isn't Quebec doing the first one in grade 6 and the second in grade 12 or something? Isn't that?
Hopefully,
Oh, they're doing 1, 6 and then skipping the last one when they get,
We've
okay.
got Dr. Olga be coming.
Well,
so-
exactly. I mean, ask this one to the vaccinologist because.
Yeah.
A year, but it's pending past 5 years. So we don't know, like if someone dropped the vaccination, went past a year, and then what do we do with that last 1 or 2? Essentially, the answer comes down to almost restarting at
Like only during that 18.
So that would be the saddest answer, but the truest at this stage. But TBA, I think there's actually a trial coming out at the extension of what happens
gonna be
in the
in
second
Vietnam,
and third in the older population, but the
and
data's
he's
not
flying
out
through
yet.
Hong Kong.
We don't have enough of it. That's robust.
And then he might be going to
You know, and the other thing is if you actually look at some, sort of drill down at some of the data in the randomized trials, there are women that got a single dose of vaccine. They do get some protection.
They do.
But I think it's unlikely they get all the
They
protection.
don't get complete protection. We don't know how long it lasts. So the
November
best is to tell
5th,
someone to quickly and
1984.
efficiently get it done. Now, there are people who do it for coverage, as we know, where they split the
Sorry,
vaccine.
sorry, November 5th,
The best thing you
1984?
can tell someone is the year that you have enough coverage, do 2 in the later part of the year and do 1 at the beginning part of the next year. So divide it that way because schools cover it that way, like SFU and other places where they give you a lump sum of money each year. So dividing it that way. Otherwise, people drop off the scale completely.
Okay.
Same
And I
with
mean, what
extended
with
benefits.
this
Mine are
family
like
comment,
that.
what
For
do you-
example, you get a certain amount of money per year for services. So doing it 6 months of the year and 6 months of the year is the easiest. So encouraging that, because dropping off does cause problems later on.
Okay,
And
that's
you just
fair.
can't tell them what to do. So.
Do we have a question?
Okay, great. Okay.
Great.
Thank you. That was really interesting.
Hmm.
Okay, so our next speaker is
Okay.
Dr.
Okay, fair enough.
Tinus Westerval. And Tinus obtained his medical degree from the University of Stellenbosch in South Africa and completed a residency in family medicine in Windhoek, Namibia, and in Stellenbosch, South Africa.
And so, for example, if he's in Cambodia
Dr.
and
Westerval has been
we're
practicing
not
as a family
in
medicine
instances of emergency
physician in Canada since
and he has to
2001,
be
with a
taken
practice
somewhere
focusing
else,
on
or
HIV
if he would
care.
rather have medical care in a different country,
Dr.
is that
Westerval
covered?
is a consulting physician at St. Paul's
Okay.
Anal Dysplasia Clinic and a member of the International Anal Dysplasia Society. So please welcome.
Everyone, and thanks for the invitation. And yes, there is an International Anal Dysplasia Society. It was just established, I think, about 2 years ago. So yeah, that's exciting. So we are moving ahead in the world of anal dysplasia. Just wondering, can everybody see me from here? Is it okay if I sit, or would you prefer me to stand? Yeah, I think I'm good with that. So my disclosures are there. I always start my talks with saying that I have another disclosure, and that I am very sympathetic to the anal canal. This is a piece of human anatomy because it's my field that I work in, HPV infection. That's often, underlooked and sort of make patients and often physicians squirmish. But it's important because anal cancer is quite a devastating disease, and hopefully mitigating my bias, I will raise your awareness of this issue today. I know that it's something that also needs to be on our radar. So learning objectives, we're going to look at the burden of HPV disease in male, look at HPV screening in males or other people, explain the efficacy of the quadrivalent vaccine in males, and talk a little bit, if there's time, about our unfortunate gender-specific immunization program. So as you all know, the HPV is a double-stranded DNA virus.
So it's raw.
There's hundreds of types. There's a few anogenital types, and you've heard these numbers from the previous speakers. 16 and 18 account for the majority of cervical and anal cancers, and the non-oncogenic warty ones are the 6 and 11. And that's just a diagram showing this family of HPV disease, from hand and foot warts to genital warts to cancer. So the HPV virus, in theory,
August 2018.
infiltrate, because it wants to be in the basal cell layers for replication through microabrasions, whether this is the anus or the cervix or other parts of the body, and the cell cycle then life cycle of the virus then starts. So how HPV actually cause abnormal cell growth is that the body has a wonderful way of, if there's DNA damage to whatever cells, there's a mechanism of DNA repair and to inhibit abnormal growth of cells. But because of the HPV virus, which is itself a mutagen, and also because of the proteins that's associated with it, it inhibits this process, one of them P53, and so there's no cell repair and you get abnormal growth of cells, being it a wart or dysplasia or cancer. So this is a slide to show the spectrum of HPV disease, and biologically, anal cancer and cervical cancer is the same disease. There are differences, but basically biologically the same thing. We start on the left with normal, cells keratinized and became enucleated in the squamous cell area. Then you get warts, going up to CIN or AIN2 and 3. We talk in the field of anal dysplasia, we just talk about high grade and low grade, till you have the whole cell layer growing aberrant cells, and you end with microinvasion, and that's the definition of cancer. We in anal dysplasia do not like the term carcinoma in situ. It just has a lot of negative connotation to it. Unfortunately, some patients who come from the periphery will still come in with diagnosis of carcinoma in situ of the anal canal. which some people actually, unfortunately, in this province have gotten chemoradiation therapy for. And in the world of anal dysplasia, we really don't like that term. It's high-grade dysplasia until it infiltrates. Looking at the clinical spectrum of HPV-related disease in male, we know genital warts, perianal warts, penile cancer, and then also some oropharyngeal cancers. And this is looking at the age-specific incidence of, HPV infection in men by age group, and we see there's a sort of a bump here, is presumably after sexual debut and probably related to sexual partners. But there's quite a high incidence, even later in life, of HPV infection in men. If we compare that, and that was all comers, if we compare it to MSM, men who have sex with men, the rates are actually much higher. And there's different reasons to explain that, whether it's more sexual partners, anal intercourse, these are MSM negative men, changing sexual practice. But so we see a higher burden of definitely anal HPV infection in men who have sex with men. But interestingly enough, in men who have sex with women in these 3 studies, not as high as from a previous slide, you can see the numbers are 50 to 60%. In men who have sex with women, their anal HPV is not non-significant. It might be up to 10%. And patients often ask me this in my clinic. I mostly see MSM patients in the anal dysplasia clinic, but 20% are just regular women who got their colonoscopies and was found to have anal dysplasia, or men. But I've never had anal intercourse in my whole life. And what I always tell patients is there's not a fence on the perineum for HPV. It's a field effect. So people get, through autoinoculation, do get anal HPV infection. Another interesting point that's been shown on this topic is that women actually have far higher rates of anal HPV infection than cervical HPV infection. Although it seems like when a woman has cervical HPV infection, there's a higher likelihood of developing cervical cancer versus the rates are 1.8 in 100,000 for women to get anal cancer. So it's an interesting phenomena. I always find that interesting, and I don't know what the explanation is for that. It must be anatomical. So this is some transmission data that I find very active. A lot of these studies about HPV transmission has been done in university students, because presumably coming into university, they've not been sexually active. University is a great time, fun time for doing a lot of things. And then looking at their HPV acquisition and developing signs of HPV disease. So in the first one, they looked at sexually active male university students, 18 to 20, followed them over a time period, and looked at detection of HPV DNA, and this is anogenital HPV DNA under their fingernails. And 31% of them had genital type HPV on their fingernails. 25% had high-risk types, oncogenic types. So that gives you an idea of how it's transmitted. Another study confirmed DNA sequencing of HPV-16 carried at both the genital and fingertips of sites of men, and this comes to this autoinoculation that I just spoke about. Another study showed HPV transmission through finger-vulvar contact in women, so it's autoinoculation in a lot of cases. And patients often ask this question, well, I have HPV disease, I don't want to infect future partners, would condom use help? And there's different studies, but condom use gives some protection, but you don't put condoms over your fingertips, right? When you have sex. So it's of some benefit, but definitely not 100%. Quoted by some studies as 60% protect. If we just look at the history of HPV on the slide, this is from the UK. From the 70s to late 2000s, the number of diagnoses of genital warts, you've seen it has improved dramatically. And I mean, whether this is changing sexual patterns, there's a lot of social reasons for this, but it's on the rise. So with that, you could say that would be a marker, what I think, of HPV infection being on the rise. Another interesting study that I found was, it's once again a university cohort, males and females. They followed them when they acquired their HPV 6 or 11, and then followed them to see what is the time until they develop genital warts. And it was very interesting to show that in females, they would develop genital warts much sooner. The males, they would be much longer lag for developing genital warts, and what you can detect from that is, do you think that is the males, infecting more females because they have no idea, maybe use less condoms because they don't have HPV on their radar, because they know they haven't been infected. And, my practice is anal dysplasia and then mainly MSM, and we deal a lot with genital warts. I know it's not something life-threatening, but it comes with a lot of psychological things associated with it, and this study just showed people get depressed, fear of rejection, they feel guilty. So it's not just a wart, it comes with a psychological part to it. Now, I don't know any of you who treat warts, there's different treatment modalities. In my clinic, I mostly use cryotherapy, but we have a lot of other options. But even at their best, they're not 100% at clearing. And if you look at the second column in the slide, they all have high recurrence rates. So my experience is like patients with genital warts often repeatedly need to come back to the clinic for repeated treatments, even years later. And these treatments are not without side effects. They can cause scarring, painful, and the psychological part. This is not a topic that's specific to male HPV disease, but it's something that I found quite interesting and in the same way also disturbing. I don't know if you've heard of recurrent respiratory papillomatosis. It's got a bimodal effect. It's either children 2 to 4 years or at the adult onset of 20 to 40, where people develop these papillomatosis in their larynx or throat. It's mainly caused by HPV 6 and 11, which is the anogenital strain. And, it's, as I say, especially in children, it might require repeated procedures to get rid of the conyloma. But this implies, and there's other studies that look at it, that actually, most likely parents transmit their strains of 6 and 11 to their young children. And it sort of makes the whole debate about should be vaccinated to me just so much stronger. Would you as a parent ever want to, or your daughter want to, transmit anogenital HPV strains to a child that's 1 year old? And it's through saliva and I think prenatal in some cases. So we've seen this slide also before. What percentage of these cancers, cervix, anus, vagina, penis, are strongly associated with HPV infection? So cervix we've heard about. The anus, they say 84%, but I think there's more recent data that shows 90%. So anal cancer is mainly caused by HPV infection. You've seen this slide as well. To the left, what is the impact on men? Penile cancer, which is luckily rare, oropharyngeal cancer, which you're going to hear about later in this talk, and might be an upcoming thing, anal cancer, and then genital warts, which we've spoken about. If you look at what age group gets anal cancer, it's mainly, and this is what I've seen in my practice, it's mainly in the later 40s, 50s, 60s. These are the patients who develop anal cancer. It's not at a young age, or even if you have anal HPV infection, and that's when we get to screening later, we'll talk about why we also feel for anal cancer screening. Early screening is not really indicated because we don't see anal cancer in young people. But we do know that with sexual debut, people acquire their HPV infection, and it takes, in most people, decades for it to develop into anal cancer. This is US data looking at the rates of anal cancer between men and women over the decades. And in the general population, women are much more likely to get anal cancer, but it's still low compared to other cancers. It's 1.8 in 100,000, and men is, I think, I can see there, about 1.5 in 100,000. But what's more disturbing about this is, once again, as I showed you with the wart slide, is from the 70s to now, anal cancer incidence rates have definitely increased. And the question is it going to increase more? And then there's questions, why is this? Is changing in socially, how many sexual partners people have, sexual practices, but it's definitely on the rise. So who would be at risk for anal cancer? Definitely people who have high-risk HPV strains, because like 6 and 11 and a few others. HIV infection is a very important risk factor, and I'll talk to you a little bit about this in future slides. Definitely multiple sex partners, smoking, because we know smoking, people who smoke do worse with HPV infection, and then people who has a weakened immune system. That is, people who are on biologics for colitis, people who have transplant, they've all been studied, they have higher risks of getting anal cancer. If we just look at men who have sex with men and their anal HPV infection rates, as I said, in the HIV negative population, the first bar is about 60%, but as their immune systems weaken, going from CD4 counts from 500 to 200 to less than 200, it's almost 100% anal HPV infection. So HPV and HIV are not, there's some symbiotic effect that people with HIV and people with badly controlled HIV has worse infection and more cancer. Interestingly enough, despite the current wonderful area where we are, where everybody, well, in the Western world go on antiretroviral therapy for HIV disease, anal cancer rates has not decreased like many other cancers has. So we, in the HIV world, expect to see a rise in anal cancers over the next few years. So I just want to, once again, just put into perspective what is the incidence rate of anal cancer. As I said to you, in women, it's 1.8 per 100,000, men 1.4. Cervical cancer, prior to cervical pap screening, was 40 to 50 over 100,000. Currently, it is 8 per 100,000. But if you look at anal cancer rates among HIV negative men who have sex with men, it's 35 per 100,000, which is quite high and much higher than the general population. If you look at the HIV positive MSM, I put a number there of 75 per 100,000, but there's other studies that have quoted up to 135 per 100,000. So it's really a group that's at risk for getting anal cancer. And to put it a little bit more perspective, colorectal cancer in Canada is 56 per 100,000, and breast cancer is 109 per 100,000, just to give you an idea. So now we're going to talk about who should be screened. Well, I don't think the general population should, the numbers are too low to have a screening program like a cervical screening program. But I don't know who of you are your family physicians. There's a very simple test that can detect anal cancer very early, and it's very cost effective, and that's how I've diagnosed 99% of the anal cancers that I've diagnosed in my life, is just doing a digital rectal examination. So if a patient comes to you for a cervical pap test, do a DRE, because most cancers are palpable. It's a firm, palpable nodule, and most cancers that I've diagnosed just before I've done these other tests. Another thing that I always tell to family physicians, or maybe, I don't know, gynecologists deal with it, if a patient says, I have a hemorrhoid, because we see this, unfortunately, I've had a hemorrhoid that bothers me now for 2 years. And they never get examined, they get prescribed anisole or whatever, and then they finally get to us and, it's advanced anal cancer. It's a very sad story. So I would really press hard for you clinicians, when you have a patient with anal symptoms, to do a thorough perianal exam and a thorough digital anorectal examination. I think it's a basic test, and you can do a lot with this. But now going to screening more specific populations. So yeah, we do, in anal cancer screening, we do a anal pap test. So it's a Dacron swab. I don't know if who of you know this. It's a Dacron swab. It's like a rough edge swab. And we use a thin prep solution, which is a liquid cytology based. I know other provinces, I think, use it for cervical screening too. And it's basically that swab gets put into the anal canal, past the anorectal junction, and clockwise get returned, and then it's put in the liquid cytology. And the terminology that we get back from the labs are much like the cervical Bethesda system. We get LSIL, HSIL, ASCUS, and ASCH. Unfortunately, the anal pap test is not as good as the cervical pap test. It's often false negative. It's very specific. So if we get an anal pap test back that says HSIL, it is HSIL. But anal pap test that comes back with LSIL, and if I do further examinations, often HSIL if you do biopsies. But at least it's the only screening test that we have at the moment. Better would be to be able to screen for HPV oncogenic strains with that. That would be a much better way, and in the States they do it, but it's not funded by our system. So who should be screened for anal cancer? Well, as I said before, like everybody over 40, when they go for complete physical, should have an anal examination. But I'm talking about the anal pap test. All HIV positive MSM should be screened. All HIV positive MSM over 40 should be screened. We have a question mark whether all HIV positive men and women, regardless of their sexual orientation, should be screened, because there's been a lot of studies to show, for example, HIV positive IVDUs who are heterosexual also have high incidence rates of anal HPV infection and anal dysplasia. Should transplant-associated immunosuppression patients be screened? We don't know yet, but it's something that's on the radar. We don't have the answers for that. And another important one, and I think there's been studies about this, in women who's had multifocal HSIL, like they've had cervical dysplasia, they've had especially vulvar dysplasia. There's been studies that show those women are very, very likely to have anal dysplasia as well if it's multifocal, and maybe they should be screened or refer for high-resolution anoscopy. So in this slide, I just want to show you what these dysplasia grades look like. So this is what I do through a microscope. This is the anorectal junction, and this is a high-grade lesion. I'll explain to you a little bit later what's the features of that. That's the pap test that we did, and those are the high-grade cells. You know, they have big nucleuses, they're hyperchromatic, and the cytoplasm are small. And if you look at the actual biopsy, the whole thickness of layer of the epithelium is aberrant cells. This is anal squamous cancer. So what you see on pathology here is you've had invasion into the stroma of the cells. This is what it looks like on high resolution with a microscope, and this is what the pap test look like of cancer. So this is what I do. This is a colposcope. We actually use a microscope, but I just had a picture, but it's similar. We put an anoscope into the anal canal. We apply acetic acid, basically vinegar. We look at the area that focus on most is the anorectal junction, similar to this cervix. It's a little bit more difficult in the anus because the anal canal sort of collapses on itself, so it's quite a maneuvering to do it. We have used basically ENT equipment to do biopsies, and then if we find lesions, we treat with, this is a laser, it's RC ablation, but we also do electrocautery of lesions. So this is what it looks like under high magnification. This is the rectal columnar epithelium, and this is the transformation zone of the anus, and there, this pink kind of fleshy, this is the anal canal, this squamous epithelium, and this is normal. If you look at this, of course, we've applied vinegar on this, acetic acid. This is what we call acid whitening, where that's probably going to be a high-grade lesion, and you see atypical blood vessel patterns there. I don't know if you can see it on the screen, when you get these little areas of punctation. And those are the lesions that we're going to biopsy and treat. This is what warts looks like through endoscopy. Warts are very friable. They're raised, they have papillary surfaces, they have different kind of blood vessels, and very hard to treat if it's this extensive. Just want to show you another example. So this is the anorectal junction. We apply acetic acid with a swab, and there you can see a high-grade lesion. They're usually flat and well demarcated. That's the same lesion, and that's the lesion that we'll biopsy and then ablate at a later stage. These are the atypical blood vessel patterns that we see with high-grade dysplasia. This is what we call punctations, like little dots, and we know we'll go and biopsy there. This is the other blood vessel presentation that we see. It's called mosaicism, and we will definitely biopsy there and then treat these lesions. This is unfortunately what cancer looks like. You get aberrant grow, and you can't see it on the slide clearly, but the blood vessel patterns become what we call atypical. So anal cancer, if detected early, is very, I mean, they get chemo and radiation and plus minus excision, but the survival rates are fairly good. But, and the key home message is, it needs to be detected early, and that's our job, because I've been through quite a few patients in my life who has died of anal cancer, and it's a terrible death. And so really for anybody involved in that field, it's really important to think of it, to screen for it if appropriate, and to do a thorough exam. In the last few minutes, I'm just going to talk about the HPV vaccine and the study that it did in men. I'm not going to talk about the bivalent vaccine because it wasn't studied in men. So I'm going to talk about the quadrivalent one, which was specifically studied in men. The nanovalent one, there wasn't a male study, so that's why I'm going to focus on the quadrivalent. So the quadrivalent has 6 and 11, 16 and 18. It's a viral capsid that elicits an antibody response to those strains. So I'm just going to look at the male part of the study. So the males were randomized to placebo versus the quadrivalent, the Gardasil. They got 3 doses, and they were followed for 36 months. There were about 3,000 men, 16 to 23, and then they had a subset of men who have sex with men, about 600, same age. And the inclusion criteria, exclusion criteria was no genital lesions, no history of warts, and a lifetime sexual partners of less than 5. And I know one of the PIs who worked on the MSM study, and he says it was very hard to recruit for the MSM part of the study. So the objectives was to look at the occurrence in the study group of external genital lesions, warts, and neoplasia, and anal neoplasia in the MSM sub-study, and they also looked at antibody titers and persistent infection with those strains. It's a busy slide, but what it showed, this is placebo and this is the vaccinated group. If you look at just external genital lesions, there was a huge rate of efficacy at up to 36 weeks of, 36 months of preventing this. If you look at, in the MSM sub-study, looking at anal dysplasia, once again, that's the vaccine group, that's the placebo group, and there's really, really a good efficacy rate of preventing future anal dysplasia. I mean, you must remember these patients had to have less than 5 sexual lifetime partners at entry of the study. The study would have been better if it was a study done on 10-year-old boys and follow them 15 years out and then see, because I think the numbers might have even been different, because you can assume if you had 5 sexual partners, you've probably had quite a bit of exposure to HPV already. But even with that, the efficacy rate was really good at preventing anal dysplasia. And then also the same for looking at persistent HPV infection. This is the placebo group, this is a vaccine group, and it was very effective. So we know that quadrivalent has been approved for use in men, 1926. Why only 26? Because the study only went up to 26. And it's approved for preventing 6, 11, 16, and 18 infection in males. They actually got the indication preventing anal cancer caused by 16 and 18, also for warts and infection. And so we know there's been a lot of recommendations from different organizations suggesting that all boys should be vaccinated started at age 9. But that hasn't happened in Canada. And there's only very few provinces who actually vaccinate their males. We know that, as a previous speaker said, the vaccination uptake in females are, in my opinion, abysmal. Once again, the Australian data are just showing what happened just to warts if they have a male or female vaccination program, and you see this dramatic drop-off of warts. And they also compare it with men who have sex with women versus men who have sex with men, and there's been a quite significant decrease. Same for New Zealand, pre-vaccination and post-vaccination, the percentage of people with developing genital warts. You know, we look at all these different vaccines, diphtheria, measles, mumps, pertussis, name it, and we look at rates of these disease pre and post vaccination. And we know most of these vaccines that has been proven to be efficacious has made a huge difference on public health. The WHO came out with this list of top 10 great public health achievements in the past century. And vaccination was number 1 on the list. And you can look at the other ones. So my questions about this female-only initiative is, are we as physicians providing the best care by only vaccinating our females? are we missing an opportunity to protect the population at risk for HPV disease? And we can talk about that a little bit more. Is it ethical that men should not be able to directly benefit from HPV vaccination? Is it ethical to leave the burden of HPV prevention only to women? And recently, our ministry here in BC, as we've heard, has now approved HPV vaccine for men 19 to 26. And these are men who have sex with men or are thinking about their orientation, street involved, HIV positive. And I think it's a small step in the right direction, but very small. Because once again, from just my own personal experience, having a practice who's predominantly men who have sex with men, from the time of sexual debut for a typical man who has sex with men to really coming out of the closet is often many years. So, you know, it's very far from perfect. And then they made this statement. In contrast, they said if they thought it would be cost effective if you have a 50% immunization of girls, that would be cost effective. So when I read that statement, I'm like, well, if you would say that about hepatitis B vaccine, because that's a sexually transmitted disease as well, potentially, if you would say, okay, it's cost effective only to immunize a quarter of the population, I don't know who would accept that argument. And for me, it's very hard to accept this argument. So what is our role? I think our role is to talk to our patients and their parents about the importance of this vaccine for boys too. And that we, in whatever capacity we provide care, we can really influence the patient that sits in front of you's future health pertaining to HPV disease. So I do recommend that we discuss HPV vaccine with parents, both boys and girls, not just the girls because it's covered. Because a lot of people do have coverage, and I think it's really important to do that. And then there's also a CMPA part of it. You know, we have to do due diligence to offer this to parents. And I think that's my talk. Thank you.
Wow. Are there any questions? Can you press your button?
Press my button. So in terms of what we should be doing in general practice for screening, you're saying more rectal exams, obviously, but in like men who have sex with men, should we be doing these?
So we feel, once again, men who have sex with men only develop cancer late 30s, early 40s and onwards. So we would, for all men who have sex with men, suggest that they get an anal pap test, I would say after, there's no strict rules, but after 35, that's a definite consideration.
How often?
We don't know. We are so jealous, we in the field of anal dysplasia are so jealous of cervical dysplasia because everything has been studied, we know exactly the biology of it, and anal dysplasia is a very new field of medicine, so we don't know. So loosely I say every time the patient comes for a complete physical, it's probably every other year. Yeah.
They don't come for complete physicals. There's no such thing in the healthy population.
Yeah. I don't work for fee-for-service, so mostly my patients do come for complete physicals. But, well, at least at point when you see them, you have to explain to them that the screening test that's available and that, that should consider it.
And technically, we just take a cotton swab and do a pap?
No, it needs to be, it's called a Dacron swab. So it's not a cotton swab. It's, if you feel the tip of it, it's sort of very...
Chlamydia swab.
Something like that. It's supposed to scrape off cells in the anal canal.
Do we need to send them to you then? Because we probably don't have these.
That's the biggest problem with screening, and that's where we have a big issue in this province because our clinic can screen. We can only treat because our current wait list is 2 years, just to be seen if you.
2 years.
Yes, it's horrific. So we can unfortunately not screen, but sometimes if you have a patient that you really think should be screened, find out from your local health authority. There's some of these community clinics that will do screening. What I've done 3 years back is I would take a cyto brush. You know the cyto brush? It's not the best way of screening, but do the cyto brush, insert it into the anal canal, do a scraping, put it on a slide and fixate it, and say it's an anal pap test. The yield is not so good, but it's at least some form of screening.
Is it covered by MSP?
Yes.
Okay.
Yeah.
Dr. Miller wanted to ask, make a comment.
Sorry, I just have two questions. One is, you mentioned the transplant community, and what we found in cervix, us privileged people, is that it tends to be people that are on prednisone specifically, not the other immunosuppressants that get the chronic recurrent CIN, VIN, etc. So I just wondered if that's the same thing you seek. So because that also applies to a lot of people who are not transplant patients with connective tissue diseases, etc. And then the second question is with regard to smoking, because we cannot clear HPV in VIN patients specifically unless they quit smoking.
Well, I totally agree with you. Smoking that's one of the first things I tell people, because unfortunately, anal dysplasia versus cervical dysplasia is very recurrent, highly recurrent. These patients, that's why wait list is so long. These patients, once you get into that clinic, you're probably going to stay in that clinic almost lifelong because you get recurrent. So yeah, and that's one of the things I tell patients when they get frustrated with recurrence, is I think you need to stop smoking. It's vital. As far as the different agents, no, I think our numbers are too small to really, differentiate which one causes more dysplasia than. Yeah, our numbers are not that big. We have a small cohort of people on immunosuppressants, so I can't say.
Hi there. So my question was, I have two questions. I have a 63-year-old heterosexual lady that was seen at the anal dysplasia clinic and has had AIN grade 2 dysplasia, is followed and has had multiple treatments. The consult letter that we had got back mentioned that there's been retrospective studies that show a decreasing recurrence in these individuals who've had HPV-related anogenital disease. So she was, in the consult, it mentioned to give her the Gardasil vaccination, so we have. Is this, I'm just wondering if this is common practice that you're offering, similar to the Cook Hospital clinic offering it to women?
In our clinic, there's no retrospective studies on it, prospective studies on it, but retrospectively there's been chart reviews done in New York where they looked at people with recurrent anal dysplasia and just compared the two groups, who got the Gardasil vaccine and who didn't. And the people who got the vaccine, there was clearly a decreased recurrence rate. What I tell patients, so I offer a HPV vaccine to every patient with anal dysplasia. I tell them it's not 100%, cure rate, or that you're never going to have, anal dysplasia again, but that's the one thing you can do, because basically what I tell patients is I can treat a lesion, but I cannot treat the virus. And the virus is obviously there. If you're 40 or 60 and you have anal dysplasia, you are stuck with HPV virus that your body obviously is not going to clear. So the only thing that you have is try the vaccine, whether it will work or not. I mean, that's your best shot at getting rid of it.
For sure. And then just another question I had was, I have like a heterosexual female, supposedly in a monogamous relationship. Her partner is monogamous. She's 55. She's had cervical dysplasia in the past, and recently had complaints of anal pruritus and had an anal tag, and worries about her risk of anal cancer. So it's kind of, again, I call Merck, and it's off-label to do the vaccine for a 55-year-old. And I just wonder the degree of benefit, if cost isn't an issue for this person. And that's kind of that gray area.
Yeah, we don't know what degree of benefit is. That's the issue. But once again, coming back just to clinical practice, what I tell patients, well, the only thing that you have to lose by getting the HPV vaccine is that it's going to cost you money.
Yeah.
There's no other downside to it. And I mean, there's unfortunately not enough studies to really make a strong recommendation. So if you recommend it to your patient, you have to tell them the caveats of this is not really studied. There's a few retrospective chart reviews in this setting. But I really think this is the only thing that we have at this moment to our disposal and other than quit smoking. That.
I think we had one last question in the back.
Yes, my question is about the genital warts. I have treated many patients, male and females, with cryotherapy, but interestingly, none of the partners of each one of them has the same thing. So I wonder how transmissible is genital warts. Like, I've seen patients with tons of genital warts in that area, and sometimes I refer them to a surgeon to remove them, but then the partner has none.
There's been so many studies. That's fascinating how HPV gets transmitted between couples, fingernail studies, oropharyngeal studies. So the DNA it's very transmissible through intimate contact. But if you think of it, most people who have HPV don't know they have HPV. That's the thing. So the partner might have that strain, the same strain, if it's 11 or 6 or whatever, that what the partner has who has warts, but this partner's immune system is just suppressing it in a different way so that there's no signs of warts. So, big question that people always ask me, especially in the special clinic, is should I disclose to future sexual partners that I have HPV? And it's a tough one, and we generally say no, because if you look at the studies if the general population who has been exposed to HPV, most people. So we don't tell people to disclose.
Great.
One more question.
Oh, a remote question?
Yeah.
Okay.
Hi, people joined by WebEx. Do you have any question? So let me know.
Okay.
Thanks.
All right. Well, thank you very much. It's really interesting. Yeah, thank you. Okay, so our next speaker is Dr. Keys, and Dr. Keys is a clinical professor in radiation oncology, UBC. She obtained her MD from University of Novi Sad, probably saying that incorrectly, Yugoslavia, and then came here and did a radiation oncology residency at UBC. Dr. Keys is a provincial brachytherapy program head. She is a very renowned speaker and author and has a very large GU and head and neck practice. So, Dr. Keys.
Thank you very much for having me here. So, just gonna figure out whether I need glasses or not. That's no disclosure apart from the glasses. Maybe I should just bring them over here. I'm in that age group. Oh dear. Yeah, I remember seeing my optometrist some 5-6 years ago, and then I left, and he said, well, you can just go to London Drugs and get his reading glasses. And I was like struck, my God, that was my sign that I'm actually aging. So anyway, I'm now used to this. So I'll be talking to you about head and neck cancer, and I think my only disclosure is that I treated most of my career prostate cancer, GU oncology, and then breast cancer. And just more recently, I've actually joined the head and neck team some couple of years ago or something. But it has been actually quite an interesting change to come back to head and neck, because when I finished my residency, I started to treat head and neck cancers, and now I come back to it. And a lot has changed, and I'll just point out to some changes. So head and neck cancer really caused a lot of mortality and morbidity worldwide, and there is a lot of cases and a lot of deaths, and 90% of all the head and neck sites actually are squamous cell carcinoma, and this is 8th most common cancer in men and 14th most common cancer in women. And these are the sites where these tumors actually do arise. And these are really traditional risk factors. So alcohol and smoking and oral hygiene and diet, family history, genetic syndromes. But it was interesting when I started my practice, I did head and neck for a couple of years. And these were all guys, like they come in and they're in their 50s, 60s, 70s. They really have a heavy odor of alcohol and tobacco, and they just kind of stare at you, and you talk to them about treatments. And they say, are you finished, doc? I say, well, almost. I just need my smoke. And they're just out of there. They don't care about what you said. And then there is HPV, which really kind of changed the face of head and neck cancers. So we'll talk about HPV a little bit and why we're concerned about this in oropharyngeal cancer, and a little bit of vaccination, which is not very complicated here at all. And I'm glad a lot has been said already, so I really don't need to say much, and you'll see why. And also, a lot of you actually asked this question. My partner has HPV-related tumor. Am I at risk, and what should I do? So we'll talk about that as well. And also about the head and neck cancers and how they look actually different than your regular head and neck cancer. So you've seen this lovely picture of the flowers in human papillomavirus, and it's a very, very common virus, and we're not going to go into that. But what is interesting is that it actually replicates exclusively within the basal layer of the surface epithelium, so that's very important. So why are we concerned? Even in 1983, it was actually first suggested that HPV might be an agent involved in the development of some types of oral cancers. And in 2007, actually, WHO stated that HPV actually causes oropharyngeal cancer. So we also have seen this. I'm not going to labor, but there is more than 70 known types, and most of them actually really cause absolutely nothing. And then there is some strains that cause benign disease. We heard about it quite a bit, and there is some, and actually there are quite a lineup here, not just 1618, but quite a lineup that cause different type of cancers. So I'll just go a little bit more detailed in how does this HPV actually cause this cancer. So what happens? So these there's some oncoproteins that these viruses actually do produce, and this viral DNA actually gets incorporated into the cell DNA, into the basal cells. And then the virus expresses these proteins, or they're called oncoproteins. They're E6 and E7. And these E6 and E7s, they actually interact with P53 and retinoblastoma gene. And so when they interact with the genes, really what happens, so let's take a look at the P53. In the normal cells, P53 is extremely important because it inhibits the cell going through the cell cycle, particularly in the face of DNA damage. And we have a lot of DNA damage that goes from smoking to sun exposure to you name it. And so this is an extremely important gene. And so when P63 actually gets binded to this E6 protein from the virus, P53 gets degraded. And so when P53 gets degraded, really that allows for unchecked cell cycling. So even though there's a DNA damage, cells are still cycling. And that actually really promotes accumulation of DNA damage to the cell cycle. So that damage is never repaired. And that, of course, leads to chromosomal instability. And that's how these high-risk HPV cells actually do get into trouble. And there is also another mechanism that really stimulates the mitotic activity at the same time of these infected cells. You have two parallel processes. And then retinoblastoma gene, again, really, there is a story that retinoblastoma protein inhibits growth by stopping the DNA synthesis and induces cell apoptosis in response to DNA damage. So again, this DNA damage. Now, this different protein, E7, interacts with this retinoblastoma gene, but then it forms some kind of a complex, and that complex, in addition to not really kind of clearing up the DNA damage that has not been cleared up, also promotes the cell cycling. So you have these two wonderful processes that actually synchronously work together. So the first process is DNA is not repaired and cells continue to cycle. And the second process is that cell cycling is actually promoted. So here you go. This is a recipe for disaster. And that's really how the recipe goes. But that takes actually a long, long time. So that doesn't happen overnight. And then in head and neck cancer, we talk about P16. So what's now P16? So P16 is a cyclin-dependent kinase inhibitor. That's another protein, very simply, another protein. And P16 is induced when this E7 protein interacts with retinoblastoma gene. And P16 is really important. It has an important role in regulating, again, the cell cycle. And mutations of this P16 increase the risk of developing a variety of cancers. So why are we talking about this? Because it's really important in head and neck cancers. This P16 can actually be stained by immunohistochemistry using mouse monoclonal antibodies. And therefore, there is a significant agreement between HPV infection or HPV-related cancer and P16 expression. So we use it in the clinic every day. It's essentially, for us, biomarker for tumor-related tumors that are actually HPV-related. There's also some discrepancies. P16 is an excellent surrogate for HPV status in our patients when we do the biopsies or resect tumors, whatnot. But P16 is not specific for any HPV subtype. So that's actually very important to understand. And so this is an H&E stain of two different head and neck tumors, P16 negative tumor and P16 positive tumor. So it's really actually very, very useful for us, and I'll tell you why. So how does HPV need to, what does HPV actually need to thrive? So it needs to have an easy access to basal epithelial cells. And when it comes to head and neck cancers, we talked about anal sites, and we talked about cervix and vulva, but really there's the crypts of lymphoid tissue in the palatine tonsil and base of tongue, and this is actually what they need. They also need some trauma to the epithelium, which I suppose it actually happens quite often in the oropharyngeal area, and also need self-differentiation and replication, which is again very common in oropharyngeal area as well. And so these are the little crypts and tonsillar crypts where the viruses actually really like to come in and then access this basal cell layer. Yes.
Is tonsillectomy any benefit to that?
Is tonsillectomy any benefit? Well, tonsillectomy is a huge benefit because you don't develop, cancer of the tonsil, but you still have the Valdeir's ring and you still have the soft palate and you still have the base of tongue. So you kind of eliminate part of it, but not all of it. So I don't know the good answer, but should we be doing tonsillectomy to prevent this cancer? I would say no, we should probably be vaccinating people, yeah. Okay, so the problem is that this persistent HPV infection, and vast majority of HPV infection we know is actually cleared in less than 2 years. So persistence of this high-risk type is associated with an increased risk of malignancy, and persistence is rare. It's very rare, so that it really needs to be underlined, but may lead to integration of the viral DNA into the basal cells. Okay, so what happens when there is a viral DNA gets integrated into the basal cells? Really nothing. Nothing happens, really. So these viral oncogenes are actually usually inhibited. And that's really where this immunity comes into a huge, it's a huge piece of puzzle. If you have good immunity, this is probably what's going to happen, nothing. So you get exposed to virus, you get infected, but nothing happens, you actually clear up the virus. However, these inhibitory processes actually may break down, and that requires failure of several different signaling pathways. And this process happened over the period of many, many years. So the time between somebody gets actually exposed to HPV until they get full oropharyngeal cancer is 10, 15, probably 20 years or more. So, and variety of these factors, external or internal factors, can actually facilitate this breakdown, and it's essentially the deficit in immunity, but also there's some environmental carcinogens, and again, the smoking comes here as a very handy carcinogen to kind of illustrate this picture. Hormones, X-rays, other viruses, and HIV, and there could be genetic factors as well. So we'll talk a little bit about epidemiology of oropharyngeal cancer. And HPV transmission is about 70 to 80% of, as we heard already, sexually active adults actually are infected during their lifetime. So majority of people actually have seen the HPV. I would say maybe all of us in this room have actually seen HPV. Let's just make it very personal. But 90% of us are going to actually clear this in 1 to 2 years. So most of us have no problems with it whatsoever as well. 10 to 30% of active infection is seen actually in young adults. And HPV is infects by direct mucosal contact. And we know that virus actually like this keratocyte stem cells in the basal layers and through to these microabrasions. And what is interesting for oropharyngeal cancer, the 60 to 70% are actually of oropharyngeal cancer are HPV related. So that's a majority now of patients that we see. And HPV 16 is actually responsible for vast majority of oropharyngeal cancer. So just one strain, HPV 16. So the issue here is not about the HPV infection, but rather who of these infected with HPV will develop persistent infection with the risk of developing cancer. And we know that being infected with HPV 16 carries a high risk, but just less than 10% of those infected with high-risk strains will actually go on to have progressive disease and cancer at the end. And we need a test that allow us to forecast which ones of those infected will actually have the cancer at the end of the day. And we don't have that test yet. So oropharyngeal cancer incidence have actually increased, and this is the SEER data until 2004. And I think these curves are actually going to look very, very different if you look at it now 10 years or 12 years later. But essentially, this is oropharyngeal positive cancer. This is oropharyngeal HPV negative cancer, and these are overall, like incidence have changed actually very little, but HPV positive cancers will actually go quite significantly up. And if you look at BC registry data, again, this is a laryngeal cancer in red, And then oropharyngeal cancer starts to go up. This is only until 2006. I'm sure this curve is actually going up. And oral cancer is going down, which is directly related to smoking. And these are the smoking rates in BC, age 15 plus until 2007. And so they're definitely going down. So most of these cancers are actually in the tonsillar area, soft palate, and the base of tongue, while their ring is in the oropharynx. And sometimes occasional laryngeal cancer can also be HPV positive or P16 positive. We don't call them HPV positive, we call them P16 positive, but most of them are really base of tongue. So these are now younger patients. As I told you, I don't see very many of these kind of smokers who just kind of want to get out of their room and have another puff, and they can't wait until I finish what I want to tell them. So these are younger patients. They're your kind of, executives and bankers and teachers and doctors who are just absolutely stunned. They're in their 50s, and all of a sudden they're sitting in your office and they have huge mass at the back of their throat. There's no history of smoking. They exercise. They're healthy, and they don't, drink much. So that's a completely different kind of patient that we see. And it's, of course, associated with sexual behavior, and the risk factors are high number of sexual partners and history of oral genital sex and oral anal sex, and decrease in the age of first intercourse for men, and genital warts and chronic periodontitis, I can't pronounce that, and abnormal pap smears in females or in their partners. Tonsil and oropharyngeal cancers increase in male, and there's this male predominance despite reduction in smoking. And so this decline in smoking history, as we saw, probably is related to overall decline in tobacco-related oropharyngeal cancer, but the change in sexual and social behavior is probably related to increased incidence of HPV-related oropharyngeal cancer. And it's really interesting, why is there male predominance? And some people think that the fact that women appear to be exposed more frequently to HPV, actually. And the secondary effect is really that they develop antibodies, and defense against HPV is the immune system is working maybe much better and much more effectively. And that's why they clear up the infection more effectively than men. So therefore, men actually has more oropharyngeal cancer. That's just a complete hypothesis, but we don't know whether that's true or not. So if you just look at the anatomy, so smoking would actually be responsible for also oropharyngeal cancers, but actually smoking and cigarettes and carcinogens actually act on the surface of the epithelium. And these cancers that are caused by the tobacco or alcohol, they look completely different clinically. So they look like ulcers, and they're, kind of typical cauliflower type of presentation. And they're very painful. In contrast, the HPV kind of gets into these crypts, and then the cancer starts kind of deep down into the tonsillar area or base of tongue. And cancer really presents as submucosal swelling, so you really don't see them. And very often you examine these patients, and you know that they must be HPV, related oropharyngeal cancers, and you can't see absolutely anything. Tonsil is completely normal, so is base of tongue. So where is the cancer? So they look also different under the microscope. Non-HPV associated tumors are usually well or moderately differentiated and keratinizing, while the HPV-related actually are poorly differentiated. They're non-keratinizing, and they have a distinct basiloid appearance under the microscope, completely different phenotype of the cancer. So often the patients present with the painless neck mass. That's the most common presentation. And usually they have cystic lymph nodes. So they're quite big, actually, lymph nodes. And the primary site, as I mentioned, may be very, very difficult to find. Base of tongue looks normal when you scope them, and when you look into the mouth, you don't see anything in the tonsils. And they really commonly have early T stage, which means small primary tumor, and then advanced nodal disease, which is these big cystic nodal metastatic deposits in the neck. And primary sometimes is actually never identified clinically, although it may be actually found on a PET scan. And so what we usually do is we send patients, or GPs or ENTs usually send patients for the final aspect of the neck nodes, and then we also do the PET scan. And as I said, 80% of all of these tumors are actually related to P16. I'm sorry, P16 positive. So it's interesting to look at now these cancers, and they're same cancer, oropharyngeal cancer, and they're actually two different, completely different phenotypes. If this is the HPV-driven cancer, so usually the primaries are small, often nodes are large. They usually have more distant mets than the other counterparts. They're poorly differentiated, P16 positive, and actually they have a very good prognosis, which I'll show you as well. But if somebody has smoking-driven cancer, they're usually large primaries and painful primaries, very obvious. Nodes are involved, but a little bit later. Distant mets are not as common. They're well or moderately differentiated, P16 negative, and then they have completely variable prognosis. Now, if you add smoking into this mixture, and somebody has HPV-driven disease and they smoke as well, this probably is actually the worst possible combination because you have two different carcinogens, and this is they have the worst of both worlds. And just to kind of give you an idea, there is a lot of Chinese population in Vancouver, so we actually see a lot of men and women who have nasopharyngeal cancer, and this is again completely different entity when it comes to head and neck site. And these oropharyngeal cancers are actually really so incredibly similar to nasopharyngeal cancer. So two different cancers, but they have same carcinogen and same phenotype. So we already said what is listed here for oropharyngeal cancer, but the same is exactly true for nasopharyngeal cancer. So these are related not to HPV, but to EBV virus, and they behave the same. They give big nodal metastatic disease. They actually really respond well to treatment, and they have actually quite good prognosis. So this